the difficulty was, unfortunately, yesterday we spent 6 hours at the funeral home because of my mother-in-law's funeral. And as I said to folks, you're hearing it again if you had micro earlier. It's been a very difficult start of the term. This is different perhaps than it was for many of you who had me last year, in the fall. There's just been a lot of preoccupation. And I apologize, and I will do so to the next class as well I don't think I was 100% on my game because there was so much other stuff going on. So I'm going to try to get back. But that's by intent. Why I gave the exams the way I did and made them open book. I could have had somebody proctor those exams. You could have done them in class. But you can imagine how difficult it might have been for many of you had I done that. And I want everybody, and basically everybody did pretty much get off with a very good grade. I would have put the grades on that. We have had some problems with the information. I was trying to make some hard copies of it, and a giant glitch with our computer, with our copying machine and stuff like that we had to attend to this morning when I got in. So I will get those probably this afternoon, if not tomorrow sometime. I'll just say exam 1 grade with scale. That's what you look at. Ignore the points. I don't want to hear a word about points ever from anybody's mouth. Please. We do letter grades here. That's my obligation. We've seen this movie before, right? So most of you did very, very well. I think there were some very limited exceptions. It was designed that way. Good Lord. Lord love it, duck. All right, moving on. So what I did, and I'll just go over here. There's an outline for this that I think is very, very useful. This blood outline. That's on your Unit 2. I've been using this PowerPoint, and I wanted to go back and use this one from the Marie textbook because I want to amplify a few points, and I think it does a little bit better job of what we're kind of hitting today, which is clotting, and then we look closely at the ABO type of stuff because they sort of intertwine. I think many of you have probably had that. That's typically something most high schools cover, the ABO system and all that type of stuff. But I have entirely too much familiarity with it, as you can find out. Moving on. So this is the part they didn't cover so much. The stuff that was dissolved, particularly the proteins. Okay? So plasma proteins are the most of those, and the one that we have, there's about 8 grams of protein typically in plasma on average, 8 grams concentration, 8 grams per. Everything you see is what we, I'm sure, maybe I didn't tell you, but I should remind you. When we see something like we say total protein is 8, what it means is that typically it's what's called 8 grams percent. And what that means is there's 8 grams of protein in 100. That's where the percent comes from. Like percent of 100 milliliters of blood. So when you hear about somebody's blood sugar, it's different. Blood sugar. When we look at the diabetes stuff, let's say it's 110, that happens to be in milligrams percent. So, you understand that when you're looking at these tests, and what I didn't do, and I'll try to get it done, because we're doing the blood unit, I will try to get this, I have to get from my computer, is you get a printout of my blood test, because you're not supposed to share anybody else's, but it's mine, I don't care. And probably the most recent is what I had about a year ago. So you get an idea of what to look at with these things from a clinical perspective. So nevertheless, albumin predominates. Albumin is a combination of proteins. Basically, for like the egg white protein is albumin. It's almost pure protein when you look at egg whites that are there. And it does a whole lot of things. It's a carrier molecule, so a lot of stuff that would normally not be able to dissolve thoroughly in blood is carried with a protein. Okay, proteins themselves are a buffer in the bloodstream. We're going to talk a lot about buffers in this. The one we have dealt with a little bit, and we're going to reiterate a couple of times, the carbonic acid buffer, that water, carbon dioxide come together, carbonic acid, and that's a significant player that we're going to be discussing now. We're going to discuss it with blood pressure. We're going to discuss it with kidney and a lot of different things. But interestingly enough, there are 2 other buffering systems. Calcium acts as a buffer. And we have a lot of calcium moving its way around our bloodstream. And then proteins act as a buffer. What does it mean? Is proteins are long, as you know, are long chains of amino acids. And on the exterior of a protein, you have amino acids, and since they're kind of both. If there's extra protons and an acid that are loose, you can latch onto them, or it can give up protons if it needs to neutralize space. That's where proteins play a role in that. If you did not know, it's something, but the single most important thing, they call it oncotic or osmotic pressure. Proteins, you might remember, this is AP1, most of you have me, they make colloids. Proteins in water are colloids. They hold on to water. Okay? And it's so important because if the proteins weren't there, when the water gets into the capillaries, which have tiny little openings, as you're going to see, both in lab and in lecture, it spits out. Okay? You all know somebody whose legs swell up. Okay, maybe an older relative had heart problems or breathing problems. We call it edema. That's fluid that comes out. What normally presents, and you're going to see it. One of the things that holds that fluid in are the proteins in your bloodstream. What's pushing the fluid out is pressure, your blood pressure. Okay, what's holding it in are the proteins. If we have too much of one or not enough of the other, there's a problem. The biggest time we see this is we see terrible pictures of starving country and little children with spindly arms and legs and big bellies. It's not fat, that's water. That's fluid has come out of their bloodstream because they don't have enough proteins. That's the definition, if you do not know, of malnutrition, is insufficient proteins. That's really the crux of malnutrition. Whenever there's a terrible natural disaster or illness or devastation by war, what do all those agencies, those wonderful agencies that provide relief, now we've cut down the number of people dying after the natural disaster because more people died after it from contaminated water supplies, unavailable protein, unavailable amounts of potable, drinkable water, etc., etc. All those things. So, I mean, it's really important. So if you look at this table, I can't really blow it up, but here's albumin. The next one are called globulins. Well, in our time together here, we're going to talk about immunoglobulins, but they're not that. Those immunoglobulins are in the category what are called gamma globulins. Alpha and beta globulins, and all of these are produced by the liver, the albumin as well. And when there's liver disease, you get those same problems with not enough proteins in the blood. Some of the things you see with hepatitis, if you ever see somebody awaiting a liver transplant, they look that way, filled with fluid because they're not making any albumin, unfortunately. And if you look closely here, produced by the liver, most again are transport proteins. And so a lot of things, when you're, again, a lot of those lipids don't, they just would clog up the blood vessels, for lack of a better way. And we attach them, even certain medicines, we attach them to these proteins. They're really important, and a lot of that has to play in the role of the genetic defects in these have to do with a lot of people with problems with fats accumulating. Even if they diet and they exercise, they have significant problems vis-a-vis that. I mean, for years, my brother-in-law has a familial history, as well as being a diabetic. He's an elite level athlete, even for his age now, which is over 80. Okay, I mean, and extraordinarily cautious what he eats. It works out. Doesn't help compared with it keeps under control. I mean, for years, I never saw the inside of the gym until I was 55 years old. And I ate anything, and I smoked like a chimney, and thankfully I didn't drink. But my numbers were always better. Sometimes it's just a heredity factor. Now I'm being more observant of the other ones, etc. And lastly, and perhaps as important as any in this unit, is fibrinogen. That ogen means it's a precursor. Fibrinogen is dissolved. Remember, fibers are part of connective tissue like blood. The fibers are called fibrin. The whole ballgame for clotting, which we're going to start taking a look at today, is we take that dissolved protein fibrinogen, we activate a pathway, and there's two, that will change it to something called fibrin. Those fibers, for all the world, and you'll see the illustration, are like a fishnet. And with that fishnet traps red blood cells and tightens up and firms up, and voila, you have a clot. The whole ballgame. And indeed, you're going to see a difference. This is a clinical difference. That's if you going into nursing and healthcare fields, you can impress somebody. Because I'll bet you one day they'll ask a question. What's the difference between plasma and serum? Okay, serum is we take blood samples, the typical tubes, and we allow the blood to clot. That eats up the fibrinogen. The liquid that's left is not plasma. It's now called serum. It's without effectively taking out the clotting factors. Minus the fibrinogen, now that's the transition between plasma and serum. So that's one of those, like, if I haven't told you, that's what when you're a resident, an intern, they're firing questions as you're walking along. You're trying to discuss a patient. Well, what's this? What's the name of this? It's a constant quiz section. So all sorts of stuff, and all the nutrients are in there, and gases are dissolved, chemicals are dissolved, etc. We already talked about these formed elements. There's some very good pictures. This is an actual micrograph. You can see the red cells. You can see the white cells in general are a little bit bigger platelets or fragments. This is an artist's rendition. This is a real thing. And white blood cells always have this, it's almost like little tentacles that protrude out. And what they do is they latch onto it. That's what they, I mean, if there's an invader, they latch onto it and capture it. Moving on. And there's a typical blood smear. I don't know, are you started doing the blood unit in lab yet? You're doing heart first, then blood? Did he have you look at blood samples microscopically yet? Okay. He may or may not do that. I don't know. I mean, when I did it, I would do it. I usually show up, for example, rather than have people do counts and things like that. And so, and we covered this already, the things that are significant with regard to red blood cells and their shape and their ability and blah, 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 and the whole hemoglobin things and alpha and beta chains. And obviously, that's the red color is an iron-based pigment that's there. Same, we saw a similar illustration in the other text where I went over this. And again, it's very, very similar. They always use like a coin, and that green thing in the middle, the heme group, that's what we can't break down. The iron would be that, like that sort of that greenish colored dot. And there it is. And it's interesting. That's what I talked about when that last thing I recorded or when I was online. I believe that was on Monday, correct? I was talking about the fact that heme is something we can't recycle. We can recycle globins or just amino acid chains. We can use them all over the place. Iron, for the most part, we can recycle. The heme is something unique about the structure, and again, it becomes a very significant waste product. There's two names. One's called, for our purposes, we're going to say bilirubin. And what that does, it has to be excreted. So it excreted, the liver forms something called bile. There's ways we excrete some of it in the urine, some in the feces. It actually gives the color to those two waste products that we produce that we're so familiar with. Oxy and deoxy. I wouldn't worry about the CO2. We'll talk to that. That's more in respiratory physiology. I'm not going to give it short shift. There's been a mistaken notion that years ago, the way we were taught, we didn't know any better. They said, well, the oxygen is riding on that iron, and when it gives up your oxygen, the carbon dioxide comes in as a waste product and takes its place. It's like it got off the bus and the carbon dioxide took the oxygen seat. Not true. We'll get to that. So, I mean, we'll get you an idea of where it rides and what it does, and it's fascinating. Okay, and we did the whole hematopoiesis. I did want to show you some of the slides. This is what I mean. All this stuff, and it's right about here. The whole idea, whether it's red cells, white cells, platelets, is for them, they all go into the blood. The whole idea is they got to get into the blood when they're supposed to be there. If they come in too late, then you have forms that are almost post-mature. Imagine the job, whether it's carrying oxygen, clotting blood, or fighting disease, and somebody, an old geezer cell coming out, it just can't do the job as effectively. By the same token, if they get pushed out of the bone marrow before they're mature, they can't do the job. I mean, I had a pathologist who taught us when I was a resident, said, basically, he said, it's almost like you're fighting a war, and you're bringing out soldiers before they've had any basic training or know what they're doing, And really, that's the way we look at it. When we see immature forms, it suggests that we're losing the battle, particularly with infection. Or there's something pushing them out, like a tumor, or some type of disease entity pushing them out too soon. So it's very diagnostic in nature. So we look for things like that. And the red cell is a good one. And I commented on it if you got a chance to listen or you're joining me online, as many of you were, with something called reticulocytes. That's part of every time you're doing a workup on blood, you do what's called a retic count. And so you walk along, you hear the doctors talk or nurse practitioners talk to say, oh, what was the reticulocyte count? So we look through these. It indicates the rate. About 1% of these cells, the mature red cells, come still bearing, we call them reticulocytes. They still have some visual elements or visible elements of their endoplasmic reticulum, some traces of organelle. There's nothing wrong with that. That's a good success. We got 99% good and 1%. Okay, maybe they're a little immature, but they may. And see, look what's happened. They get smaller. Maturation usually means getting bigger. The whole idea of maturing is to shed your nucleus. That's the reticulocyte. You see little elements of some type of endoplasmic reticulum or similar structure. And then finally, we get to the erythrocyte. So when we have anemias, when people do not, what happens when someone has, the most common ones are various types of iron deficiency, internal bleeding, external bleeding, diet problems, disease entities. Those red cells get smaller because there's not enough iron to go around, and they're paler. So we call it a microcytic, smaller cell anemia. When it's not maturing fast enough, it means it stays big. They're more of this side. That's called a macrocytic anemia. That's kind of like what I have to a certain extent. Mine probably has something to do with B12 or absorption of elements from all the stomach surgeries that I have had. So and these are little, you get I can't tell you how many people I consider mentors in places I have trained in over the years. You get so much information from doing a complete blood count and a urinalysis, it boggles the mind. That's why they're easy tests to do. One stick, and you're basically pretty good. You can get a blood count. The same stick, you can get what we call a metabolic panel. Urinalysis is pretty easy to achieve. And then you really have a very good idea of overall health. At the very least, you can determine whether somebody is healthy enough to undergo a surgical procedure, which is often all the information you need. You don't need to do exotic. If you have to do exotic stuff, now you got to figure out why doing that. So the whole idea, you got to have this stuff. Too many or too few are problems. Okay, we make them. Look how many we make every second. Want to do the math to figure out how many seconds there are in a day? Oh, I mean, we make a slew. It's going to use another term, but erythropoietin we covered before. Different kinds of controls. We don't have the altitude is a big deal. We revisit the altitude thing again. And these, now, if you're at altitude, I mean, we have people in from Denver for the funeral. If you and I go there and don't live there that first time, it takes about a good 2 weeks or so to compensate for the fact that you have less oxygen. You actually begin to make more red blood cells. Your blood gets thicker, but not so much so that it's dangerously so. The people we see with inordinately thick blood, it's a real significant problem. That's people with respiratory diseases, emphysema, chronic obstructive pulmonary diseases. We talk about in the respiratory unit. The tragedy of this is their lungs don't work. So your heart doesn't know this. All the heart knows is I'm not getting enough oxygen. And what the heart does to compensate, it works harder. When it works harder, it needs more oxygen, but the lungs aren't going to magically get better. So, and it's like a vicious cycle, if you can imagine that. The heart continues to work harder to compensate for lungs that will never bring more oxygen in. And eventually, something's going to give, and usually it's the heart. That's what we see. So you end up in any irregularities like this, as you will see when you do your cardiovascular unit. We have a word for failure, heart failure. What induces the failure is the interesting part. So that's just some of the things. Let's see. I talked about that. Talked about that. Don't do the teeter totters. Yeah, this is that's the cycling, which is really where the problem was. They basically, if you saw, remember that tube that spun the centrifuge, what cycling did before they used erythropoietin. Now they just would take their own blood out and re-inject it. They'd save it. Blood was going to keep pushing up those red cell counts that were there. I don't go into this. This is the iron transport. There are diseases that have to do with this. This hemosiderin. These typically indicate diseases where we're unable to transport sufficiently or we have abnormal storage. You will see this. Some of them are even immunologically based diseases. My remarkably good memory one day made me look very smart because I remembered there's a disease called hemochromatosis, and they call it bronze diabetes. And it has to do with this. The iron has nowhere to go, and it stores it in organs, and eventually it stores it in the skin. You look like you're very, very tan, that iron kind of color. But at the same time, it's destroying your organs, one of which is the pancreas, and you can't make insulin. So they nicknamed it bronze diabetes. It's really not a classic diabetes. And I was here. I was a student with a bunch of residents, newly graduated doctors and residents, and the attending throws that question out, and guess who answers it? And all of a sudden, I'm hearing secondhand, Doctor, his name is Dr. Arthur. Dr. Arthur wonders why you're smarter than the interns who just graduated medical school. I said, I read a lot, my usual comment. So I give these to you to understand that I think I phrased it the right way. If you haven't figured it out by now, when you do well academically, we all have access to your numbers. And here's the mindset of thinking is, here's this student A, he, she, whatever. Okay. And I'm saying they get all A's, B's, all A's and B's from everybody else, and all of a sudden they're not doing well in my class. You tend to get you in the back of your mind. It goes, I wonder what I'm doing. Maybe I should revisit this. Your track record impacts who's grading you going forward. Believe me, that's how it works. It's a trade secret. You need to understand that and exploit those. Many of you already know this. Set the record. It pays to look smart. Telling you the truth. See, I know that, so I don't look at it that way. I'm here. I gotta call you later. 3 o'clock, I said, not now. So again, this is sort of the lifespan stuff. So I wanted to go over all of this. They get recycled. You don't have to go crazy. This is the Billy Rubin production and where it goes. A lot of graphics associated with this. So I'm buzzing through this. The difference is when the blood is too thick, we call it polycythemia. If it's not being induced by being at altitude or respiratory diseases, you wonder if somebody's doing it intentionally. And that poly means too many. There are even diseases where this occurs normally. We call it polycythemia vera, like verifying. Vera is the truth, verdad in Spanish. So vera is a rare instance of this. Most times they're secondary to other causes. And anemia, from whatever reason, losing it, not being produced, being destroyed. And this is the point I did want to make to you. The really significant point I wanted to make to you about all of this is what anemia means. And unless you have had it or know somebody who has had it, you can't understand how severe the concept of fatigue is. Being a time about 27 years ago, 1998, 2000, that step's out there. Okay, how hard is it to walk up those steps? I could not walk up all of those at once. I could walk up 3 and have to stop. My blood count was 1/3 of what normal was. was a chronic blood loss. I talk about getting into an accident, somebody trying to almost running you over, which you folks were talking about when you came in. Pardon? Yeah, I couldn't have made it across the street. I was that person who got parked at the Giant Eagle lot, and traffic would have to stop because it was like a 90-year-old with a walker trying to get there one step at a time. Yet it was not even a 50-year-old doing it. Imagine that. That's the severity of fatigue that you get with this. If you did not know, at that point, I probably received, and as we get to the transfusion issue of it, I have had, I dare say, 50 units of transfused blood over a year and a half to 2 year span. My bleeding was so severe before I was able to finally have the surgery and get everything corrected. And that was the second of those type of surgeries for ulcers. So this is a personal unit to me because I know specifically what was going on. All right? That's part of it. So mine was blood loss. It was hemorrhagic, but not from a wound where it's rapid and life-threatening, but chronic. And it wasn't hemorrhage, it was a bleeding ulcer. Except it wasn't one bleeding ulcer. At one point I think I had a dozen. Now, you guys don't know it. I've been close 3 times. Most recent in 2006. Okay? And so, and always you treat the underlying disease. Transfusions are a Band-Aid. You always have to find out what it is. And this is what I meant. When there's not enough iron, for whatever reason, or you're losing blood, they're small, they're pale, iron supplements work. But again, you have to find out why the blood loss. This is probably what I have now, a variation of pernicious, which typically involves, they think it's autoimmune. Mine was probably post-operative. This intrinsic factor is something we get to in digestive. Without that, you can't absorb B12. B12 is part of the maturity. Folic acid is a little less problematic. But B12 has been around by injections, nasal gels. The only problem is not even vegetarians, probably vegans. Something that's serious. Most B12 that we get in vitamins come from animal sources. Okay. So you can go online and find it. It's just expensive. You look, I need vegan B12, go on Amazon, you'll get it. There's other ways to get it. It's just more expensive. It's there. And this is, I think I shared with you about that already, about when we talked about erythropoietin in the endocrine area, that renal anemia is part of it. Well, a plastic is the ones I'm familiar with have been more induced by medications, and certainly post-radiation or cancer chemotherapy type stuff. And then this gives us the hemolytic anemias. This is abnormal hemoglobin. Typically, they are genetic disorders. Sickle cell is probably the best understood. This is thalassemias, and there's a range of these, and we'll look at them in clotting a little bit. If you take a course in genetics, and maybe you have an assignment to look at what's called familial Mediterranean fever. Okay, it's bleeding disorders that are common in folks who live in and around the Mediterranean, and it involves clotting factors, but not the famous factor VIII deficiency, which is what we call hemophilia type A, which historically is the most famous crown heads of Europe. Queen Victoria, 9 kids, she passed it on to everybody. Frisky. Sorry, but that's how they cemented relations. You married, it's one big happy family all over the crown heads of Europe. So here's the sickle thing, and again, the point I made was it's just this problem. The trait's no bargain. We used to think the trait was just a trait. We know now that is not the case, and the benefit people with sickle cell do not contract malaria. Malaria affects hemoglobin. And malaria is the biggest, you hear me in micro, for those who have me, the biggest single killer in sub-Saharan Africa, more than HIV/AIDS, which most people think it is. Different ways it can be treated. There's the classic sickling that you saw. Here's the polycythemia. Too much, you can pull off blood. The secondary type altitude or respiratory problems. This is the one, this is the blood doping, which is pervasive. and certain things, and all the white blood cell things, and all of this we covered. Less than 1%. Remember, red blood cells, there's 4 or 5 million. This is 4 or 5,000 per microliter, 1,000 times more. Okay, we did the agranulocytes and granular. Here's that. Never let monkeys eat bananas, which I think is cruel and unusual. But you need to remember that. Okay, nothing else for the monkeys in your life. And all it means, these are the most, from most abundant to least, the highest percentage to the lowest percentage. Know a little, what I call a nugget about each one. That's part of the differential. It's so valuable. If that's normal, then you can be pretty comfortable that there's not an active infection or some inherent problem with their immune system. Here's their pictures. See, the granules are evident because they stain here. They are what they call not noticeable. There are granules in there. They just do not stain. They're so small that we don't visualize them. So it's an agranulocyte is a misnomer. It's more of an optical illusion misnomer. And you can read through this and how they. When we do immune system, we're going to go over this again. Like this respiratory burst. Remember, all the time I've talked about those toxic derivatives of oxygen. Okay, effectively, imagine a white blood cell spitting that out at bacteria to kill it. One of the ways we treat for forever is we expose things to oxygen. We use hydrogen peroxide on a lot of organisms. That's the idea. And it is another way. Okay, how do we get the stuff in there? These are called defensin granules. They secrete these little granules, like little spears. They poke holes in the membrane and then blow in chemicals to burst it. That's pretty clever for a white blood cell. I wish I thought of that. I'm trying to be that. Allergies and asthma, worms, mast cells. Let's remember, monocytes become macrophages. These become effectively mast cells. Very big player when we start looking at immunological diseases. The hint you're getting here. I basically make immune diseases not quite a standalone. I typically do blood vessels and immune, like blood pressure and immune in one test unit. Your next test unit is probably going to be blood and heart more than anything else. And then everything else is the final is everything after that. This is why I want to get through the blood and then do the heart physiology. So so heart anatomy, you say you're doing heart anatomy now? When are you going to dissect it? You did? Did you use a sheep heart or a cow heart? Cow's bigger, but they're much more expensive. Okay. So you got all the things, you poked around to see which one is the superior vena cava, which one is the, I got you. God bless. What a country. See how big the chambers are? The quarter tendony, guitar strings. Love it. But you know what I do when I hand out the hearts? I play the Tin Man going, if I only had a heart. You don't think I've done that? Oh, you're sure I've done that? His son, Jack Haley Jr., that was Jack Haley who played the Tin Man. His son married her daughter, Liza Minnelli, was one of Liza's 6 or 7 husbands. You know the old motto, if at first you don't succeed. And we'll talk, and we'll go, all this monocytes become macrophages, gobble up everything, voila. And then we'll get to all of these interleukins a bit when we do immune. Immune is an immense unit. I've tried to keep it as simple as possible. Again, you don't get, this is what I was talking about with immature forms, if you're wondering, when I was wanting to mention that to you. They're called band cells. When we would look for these cells, on a typical, if we're looking for infection, because if you see a band cell, it strongly suggests that this is immature. The more you have of those, your bone marrow, when it gets signaled that there's an infection or an invader, it starts pushing out cells. Okay, that's a good thing, but after a while, it keeps pushing them out before it's made. So you get, if you have too many immature forms, it means one of two things: either you're early in the fight. It's a little more ominous because there's ways you might be losing the fight. When you're losing the fight against a significant infection, then you lose the battle. That ain't good. Now you can see 10 times more are stored in bone marrow than in blood. 3 times more white blood cells are formed than red blood cells because white blood cells have a shorter lifespan. And we'll get into all that when we do immune. I don't do any of that stuff, etc., etc. Now we have stem cell transplants and bone marrow transplants that have really become very, very useful. And even this type of thing, when we're trying to find ways to improve people with AIDS, it's a fatal disease, but you're just trying to improve their lifespan. And then again, leukemias, mono, then you have a very, very high account. So typically it's infectious or leukemia, which is a tumor. Leukopenia, yes, it can be something that's associated with, there's been antibiotics and certain medications that have led to having the bone marrow suppressed. Cancer drugs certainly can do it, but then the other one you really worry about is if they're HIV positive. Now they're on that very slippery slope going toward AIDS, unfortunately. I mean, I'm trying to give you this broad brush style. And we see them more common, acute in children. I mentioned this in passing yesterday, chronic and older. And they all have to be treated, just some it's much more difficult to deal with. Okay? There's so many problems. And again, the fact you have more white blood cells doesn't mean better. You have more non-functional white blood cells. So I mean, the different white blood cell is only good if it's mature and if it's enabled to fight the job it has to. And here I started to talk about this a little bit in micro today with EB or Epstein-Barr, high numbers of this type of thing, typical agranulocytes, and begin to see increasing numbers, mostly lymphocytes and even monocytes. So they originally thought it was just monocytes, so they needed mononucleosis. And again, these are the typical things. You have an excessive amount of something in the blood that limits oxygen carrying capability. The little niggly kind of aches and pains we get that our white blood cells don't deal with so good. Okay, sore throat is something that's very common that we keep under wraps. Okay, low-grade fevers, all of these. You have almost like a smoldering inflammatory response, which a healthy immune system would get rid of. Like tell yourself, how many times have you woken up one morning and go, I just feel something coming on. And then the next morning, it's like, oh, I feel better. It must have been that 24-hour bug. There's no 24-hour bugs. It's your immune system basically taking over and going, I got it covered. You go to class. You take the day off. And then the next day, it's like, hey, let's go. That's the way it works. Which brings us to the platelets. And even though I was hoping to get more in there, I'd rather have covered that in general. This is the clotting. Know now that we are under the notion, erroneously, too many people, that basically, when does your blood clot? When we hurt ourselves. Oh my gosh. Fell, I got a scrape, I cut myself, put pressure on, pressure stops all bleeding, blah, 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 blah. That is an infrequent. Unless you're particularly accident prone or what we like to say klutzy, which I am the definition of. I have a Klutzes R Us card here buried someplace. Understand, most of the system that is constantly clotting is the maintenance system. You're going to learn it's called the intrinsic system that's in your bloodstream. Your blood vessels are miles, not a mile, not 10, probably millions of miles of little roadways that are constantly just like subject to wear and tear. And what happens when there's wear and tear, they form areas that have to be repaired. That's the role of the intrinsic system. It works all the time. Thankfully, you don't know it because it's working properly. The one that we use very infrequently is called the extrinsic system. meaning it relies on something that's outside of the bloodstream to make it clot. And that is a factor that comes when tissue is damaged, called tissue factor. So there's two types. They both all end up in the same direction. One works very fast, hurting yourself. One works continuously, reliably, slowly. So all of these things, and there's a whole lot, those little granules, remember it's a little bit of membrane with some granule in it, okay, have things that activate it. Serotonin, I know it's a neurotransmitter, but in this, it tends to cause blood vessels to narrow. Calcium is part of the entire clotting cascade. The enzymes are the clotting cascade. Energy sources. And this interesting guy called platelet-derived growth factor, PDGF. If you know somebody who's gone to a wound healing clinic, what they do is they extract from their own blood, platelet-derived growth factor and apply it to slow healing wounds because it will stimulate new blood vessel growth and then new linings that come on top of it. It's part of the crux of modern wound healing. I mean, I don't know a lot. I mean, one of my mentors was doing wound healing before anybody knew what was going on. I was working with somebody who was at the cutting edge of wound healing down in Richmond, Virginia, 50 years ago, before it became part of it. Yes?
Like, would that be applicable to, like, say, like a soft tissue injury, like, say, a labrum? Like, would they use...
They use platelet-enriched plasma, PEP. So, and that was, everybody, for instance, Tiger Woods, when he's had a lot of problems with his knees, what they did when he originally hurt their knee was they were getting peat, they would take it out, platelet-enriched plasma, they take urine and yours, somehow concentrate and stick it into a joint. That's probably what you're referring to. Platelet-derived growth factor is more applicable of wound healing. That other, what they thought, would enhance cartilage redevelopment. And that's broad brush. I mean, the short answer is I do not know the exact mechanism. And people used to go, oh, you know, because they thought because he was so that much better than everybody else. Oh, he's got to be using some kind of performance-enhancing drug, and that was a common. So the circulating platelets are kept inactive, and you're going to learn. We talked about it a little bit. There's a chemical you're going to learn about called nitric oxide that we're just finding out now that plays an important role in lining cells and blood vessels that basically keeps it from clotting. So that's a really important chemical. They all start from a common ancestor. Normally we see this common ancestor dividing and making lots of little cells. This common ancestor, called a megakaryoblast, is this giant cell that constantly replicates but doesn't divide. And what happens is little fragments of platelets. It's like you have a big mass of goo, and you put it like in a strainer, and you sort of push on it, and little pieces will come out like they would out of a strainer. That's kind of like you have a little colander, the little holes in it. You can sort of imagine that being an analogy for it. I'm having a pasta moment. It's like a pasta extruder. You ever, I love that. I should have been born Italian. Oh, my daughter gave me, my affection for the Godfather movies. So she knows that. I was waiting for somebody to ask me for a favor because my daughter's wedding day. Part of the Godfather. It's an old movie you probably didn't hear about. She got me a t-shirt that said The Bride Father. I'm wearing it when the weather gets nice. One day many of you are going to make, you gals are going to make your dads go through what I went through. Oh, yes. So mitosis, but no cytokinesis, they don't separate, okay? And basically they break off these little fragments, not a ton of lifespan. And you can see we have a whole lot more than we have white cells. That's what I mean. It's this giant cell, and that's what comes out of it. So we call them formed element. It's not a cell, certainly, but it's not just a chemical, certainly. And so I will stop it there, and we're going to go all into hemostasis next time. Probably blood typing on Monday. Thank you.
That's